Good afternoon and good evening. Thank you so much for joining us on our Mastering Patient Selection and Risk Stratification for TAVI webinar. My name is Tiffany Hanchett, and I'm one of the Senior Product Managers at Abbott Structural Heart, and I will be moderating today's webinar. Here at Abbott, we really care about the role you play in supporting your patients and helping them access therapies to help them live longer and better lives. We know your time is valuable, so thank you so much for joining us this evening as we discuss tidbits of information that we hope you find value to your practice. Before we kick things off, I want to let everyone know that this webinar is being recorded. We plan to post it online in the coming weeks. So if you need to jump off early to head home and or be with your family, don't worry, you can still access the recording later. Also, if you have any questions, feel free to use the chat box on your screen. We highly encourage you to ask questions here, and we'll do our best to respond to those questions throughout the webinar. And if we don't get to it, don't worry, at the end, we'll recap all the questions and answer any new questions. Now, I'm excited to introduce our three expert speakers. So first, we have Martha Aguirre. She is a proud Atlantean and a wife of over 20 years and a fur mom of the cutest golden doodle who ever walked the planet. She graduated from Georgia State University with her associate's degree of nursing as a valedictorian of her class. She then went on to complete her bachelor's of science in nursing at Walden University, where she graduated summa cum laude. Martha's career in cardiology launched at Piedmont, Atlanta. She started as an RN in the cardiac step-down unit, caring for a variety of post-catheter interventions patients. She soon became the nurse educator for the unit and eventually a charge nurse. Throughout the years, Martha discovered that structural heart is awesome. That led her to join Marcus Heart Valve team at Piedmont, Atlanta as a nurse navigator in 2022. In 2023, she moved to the valve clinic coordinator role and hasn't looked back ever since. Next, we have Sarah Kennedy, a nurse practitioner with over 10 years of experience in structural heart cardiology. With a strong clinical background in critical care and cardiothoracic surgery, Sarah currently serves as the lead APP for the structural heart program at Sentara in North Fork, Virginia. She is a graduate of James Madison University with a bachelor's of science in nursing, and then went on to earn her master's degree in nursing from Georgetown University. In addition to her clinical role, Sarah is deeply involved in cardiovascular research and innovation. Sarah has served as adjunct professor at Old Dominion University, and with a passion of improving patient outcomes through clinical evidence-based practice, research, and collaboration, she continues to be a leader in the evolving field of structural heart disease. And finally, we have Caitlin O'Callahan-Reen. She's the clinical lead and coordinator for strategic programming initiatives for the structural heart program at Massachusetts General Hospital. Caitlin was recently promoted to the esteemed level of Massachusetts General Brigham APP Scholar, which is the highest level in their clinical framework. She also earned her FACC from the American College of Cardiology and was induced as a fellow in March 2025. Congratulations. Caitlin completed her associate degree of nursing at Regis College, her bachelor degree of science of nursing at Simmons University, and her master's degree of science nursing at Boston College. She has been adjunct professor of multiple nursing schools and currently serves on national committees, including the NCDR Impact Registry, Executive Planning Committee, the Cardiovascular Professional Work Group of SCI, and a member of the ACC Editorial Advisory and Public Relations Board. Thank you for our speakers, and I will now hand it off to Martha.
Thank you so much, Tiffany. So my name is Martha, and I just want to start by doing a broad overview of our patient selection and workflow optimization. And then Sarah and Caitlin are going to be doing a little bit of a deeper dive in just a moment. So I always want to start by saying, we learn a lot from where we're going to go from the past. And even Confucius said, study the past if you would define the future. So many of you know the first TAVI was performed in an inoperable patient with critical aortic stenosis back in 2002. TAVI first came to the US in 2004, and within 15 years, TAVI became the therapy of choice for select patients. So, understanding how quickly TAVI is advancing, we need to figure out how do we better streamline our processes and also maintain those great outcomes that we all want. So the framework for patient selection, our processes are very similar. So we start with referral. All of us get a consult with a cardiothoracic surgeon and an interventional cardiologist. We all do patient education and tracking, diagnostics, of course, the multidisciplinary valve team meeting, and TAVI. So all of our programs do look somewhat different, but those main steps are apart. So then when you consider for your referrals, here at Piedmont Atlanta, we're on track to do about 700 TAVIs this year, and that's an increase of about 100 from what we were doing last year. And I've talked to several programs, and everybody's kind of saying the same thing. And where are all these patients coming from? So first of all, of course, we're still getting those referrals from established relationships with our area cardiologist, but we're also getting a lot of referrals straight from primary care. And of course, that itself comes with its own challenges, such as your TTE imaging quality may not be what your program's used to. And that's a difficult conversation to have because you certainly want to maintain those referral relationships. And I can say that from our program standpoint, we have successfully partnered with our vendors to do some outreach programs that's really been helpful. We're also getting patients that from an echo mining software, and that's its good and its bad. You get patients that otherwise have not been referred to a structural heart program that really should, but then you also get a lot of junk, and how do you filter through that? And then, we just have received approval to treat these asymptomatic severe aortic stenosis patients. And we know what's coming, which is a dedicated valve for aortic insufficiency. And we know Oops, sorry about that. And we also know that we're soon going to be able to treat moderate aortic stenosis, very likely, and that AI predictive modeling has opened up TAVR options for patients that previously would have had to have open heart surgery or medical therapy. So how do we handle all of this extra volume? So that's a question for you guys. Please put it in the comments. Caitlin, Sarah, I don't know if you guys want to jump in. How are you all handling all this extra volume?
Yeah, no, that's a really good question. And 700 TAVRs, that's incredible. So you guys must have a really well-oiled machine to do that kind of volume. Yeah, it's tough, and we're constantly reworking workflows and trying to find administrative support to take some of those tasks on of just organizing and the pathways to get patients through quickly. I don't think we have a formula that we could share that's perfect because it's constantly evolving. But yeah, we are also feeling that stress.
Yeah, I think we all are, and I think one of the things that would be helpful going forward is making sure when you're seeing this extra volume, make sure everybody in your team is working to the extent of their license, right? Make sure that you're doing the right things and the right people are assigned to the right task. That skill task alignment I find is really important when you see that volume and sort of those floodgates opening. Make sure everybody's doing what they're supposed to be doing and working at the highest level of their degree.
Yeah, I think those are all great points. And I think that as we go along, we're all going to learn the different things. So, next let's look at this consult visit. That's really when patient selection starts, I feel like. So every program does it differently. Every cardiothoracic surgeon doesn't see the patient on the same day as the interventional cardiologist. Some programs do. But we all consider somewhat of the same factors. So frailty, is the patient robust enough for TAVI? I think that as we gain more procedural experience, that answer is more often yes than no now. Surgical risk, your STS score, and then the eyeball test. Sarah's going to dive into this a little bit more in just a bit. And then your past medical history. What are you really caring about? What is the most, important factors to consider? So, of course, we're thinking about the patient's age. So now we're treating younger and younger patients, and we have to think, what are we going to do in 10 years for this patient? Or what are we going to do in 20 or 30 years? So we're really starting lifetime management planning on that day of consult. And then TAVI research is very robust. So you're thinking, is there any exclusions? Or do they have end-stage renal disease? Do they have coronary artery disease that's not been treated? Do they have cancer on active therapy? And then you have that difficult question. The guidelines say that we have to have a life expectancy over a year. And we know that it is futile to treat a patient, but then you have to consider their quality of life. So that can sometimes be a difficult question. And then, as I mentioned earlier, we're treating these younger patients, so we're getting more patients in that have already had a previous procedure. So you have to think, is this a native valve? Is this a prosthetic valve? Because they're going to behave differently. And then you want to document your heart failure and symptoms. And that also is going to play in later on to make sure that we're getting fully reimbursed. So it all really comes down to the guidelines, and Caitlin's going to go over those in detail in just a bit. So then let's talk patient education and tracking. So another essential step of the patient pathway is education. It's a crucial component of that shared decision making, and every team member plays a part, but I feel like the burden falls to the nurse navigators and valve coordinators. Again, every program's different, and so many of you are doing it by yourself, and you're it. That is so remarkable, and I applaud you. That it is so difficult. And then we also have to think every program divides our patients differently, some by valve disease, some by physician. Our program divides by alphabet of the patient's last name. But the one thing you want to make sure is that however you're doing it, that you're doing it the same way every time, and that every person in the organization, every person in your heart team's doing the same thing. Because the risk with variability, if everybody has their own method, is that there's a risk for patients being lost. And I think that's probably the most stressful part of my job as a valve coordinator. And I'm sure many of you would say the same, is we don't ever want to have that patient that's lost to follow up. We want to make sure that we're keeping up with everybody. So some of us use valve tracking software to do that. You can set a team meeting date and reminders. Some of us use lists in the EMR. Some of us use Excel. I hazard to say that there's probably no perfect system out there, but as long as you're doing it the same way every time, then maybe we can hop along until we find something that works better. All right, so let's jump in a little bit to the diagnostics. We talked about that TTE that's usually done prior to the referral. And then we are also looking at the CTA with the getting your TAVR measurements and looking at your coronaries. Most programs, I think, are now just doing a coronary angio if there's a concern on the CTA or if they've had previous grafts. But otherwise, we're not really focusing on that too much. And I know Caitlin's going to go into these a little bit more later on. So I won't spend too much time there. But I do want to talk a little bit about how the CT TAVR plays a role in patient selection, especially for the Navitor TAVI. So when you're thinking of your annulus size, the Navitor TAVI maximizes that orifice area, and that's especially important when you're thinking of patients that have a smaller annulus. It generally ranges, between 300 and 700, and that smaller annulus patient is going to need to get the best EOA or effective orifice area in order to get that lower gradient post-procedure. So maybe that would be a reason why you would consider Navitor TAVI in some of the smaller patients. And then you also want to look at the coronaries and the calcium. We'll look a little bit more at that in just a second. And then your access. So if you have patients that have a little bit of a difficult access, or their peripherals are on the smaller side, sometimes FlexNav is a good option for those patients because it's that integrated 14-15 French system and is pretty flexible. And then, of course, that coronary artery disease that we were talking about. If it's clinically significant, you want to make sure you're getting that invasive coronary angio, especially in those patients who are low or intermediate risk, because that might change the plan. Is that patient better to get AVR cabbage, or is this somebody that we can do a staged PCI or a TAVR? And so there's so many options. So that's an important consideration. And then incidental findings. You know, this is probably one of the biggest hot button points that I'm hearing about lately is what are our heart teams doing with these incidental findings on the CT overreads? Are they impacting our TAVI decision? In some cases, we've found patients that had an undiagnosed cancer that's pretty advanced, and that needs to be worked up before we move to TAVI. Other times we're saying, hey, yes, there's something going on, but let's go ahead and TAVI to facilitate them being treated. But also, who should follow up? I know a lot of our structural heart teams were so busy, we don't have time to follow up all those incidental findings. So in my program, we're sending those over to the primary care provider to follow up so that we can focus on our structural heart patients. Is anybody doing anything different? Caitlin or Sarah, you guys do anything different for incidental findings?
No, we do the same, but I think it's a hard thing to figure out, right? Because you have found it, you have to own it. And I think being in structural heart, we're all very bad at delegating. We like to sort of take control and own it from the beginning to the end. But in order for that to be, really evaluated correctly, I do find that the primary cares actually do a much better job than I think we would do with this.
Mm-hmm.
So we used to sort of just send a quick in basket or an email, and there wasn't really any closed loop communication. So it was a little bit concerning, like, did they get it? Are they following up? So we do have sort of a way in our program to follow up to make sure that somebody is taking a peek and the correct, follow up is in place. But it's tricky, and I don't think there's a right way. I'm not sure what is the most efficient way, what maximizes, everybody's work time, but that's just what we've done, and I think it worked pretty well.
Yeah, I would echo that. It's definitely a stress point because you're doing thousands of CTs and you're finding thousands of pulmonary nodules and dilated ascending aortas and kidney stones. And so I think one point, we do the exact same thing, usually filter it through the PCP, but I think another important point is when you're talking about the halo effect, kind of capturing that for your valve program you refer to the thoracic clinic, to the aortic clinic, capturing all of that into your program.
Another point I'll make is, people have access to their charts now, right? So sometimes they will call you and say, well, I saw this, this, and this. How come you didn't tell me? And that's a tricky conversation sometimes to say, we're aware of this. We've involved your local teams. So, being efficient with this and making sure that you are following up with those long, big in baskets that we have. There are things in there that can't wait 24 hours. You have to really keep on top of this. And with patient access to their records and their charts now, it adds a little bit of stress to it.
I think those are all great points. I do really like the closed loop communication. I think that's something that could be improved here in our program just to make sure that somebody actually sees it. Thanks for that. All right, so moving on, I touched on these coronary occlusion risk factors. Again, this is pretty broad, but coronary heights that are under 10, sinuses that are under 28, a leaflet elongation in relation to your coronary height. So you kind of got your coronary height here and your leaflet falls over here. And then when you put the TAVI in, it comes up here. Chunks of calcium that are not evenly distributed. So you got more on one side than the other. And a female sex, those are all risk factors for coronary occlusion. And I know Caitlin's going to show us some really cool challenging cases later on that will look at some of that too. And so then the high calcium burden. So maybe it does, maybe it doesn't increase the stroke risk based on which study you look at. But distribution of the calcium definitely plays a role in PVL. Also does increase your risk for annular rupture. There is some evidence to say self-expanding valves may reduce the risk of PVL and annular rupture in some instances. But again, this is something that your heart team just really needs to look at. So in our case, we're doing something called predictive modeling in a lot of these patients. So this is an artificially artificial intelligence assisted program. And this is a deployment of a Navitor TAVI inside of, there we go, inside of another valve. So it's a valve and valve case. And you can see with this predictive modeling that you get a really good visual of where things are going to fall, which is a lot better than, trying to scroll through and look at your different pictures. So this can help predict your coronary occlusion and your rupture risk. So then when you get all this information together, you're ready to go on to your heart team meeting. So who are the players on the team? So it's interventional cardiology, cardiothoracic surgery, your valve clinic coordinator, your structural heart imaging specialist, your advanced practice provider, your nurse navigator. And, each of us plays our own role, and we're each essential to this shared decision-making time here. But I would say that the valve clinic coordinator really holds a lot of the burden of making sure that we have gathered all of the information from the time of referral through all of the diagnostics. And then we've looked at those diagnostics and we've done whatever we can on the front end before the meeting to make sure that we have a really good, complete picture to present to the team. So some of the things that we're considering as we're getting this patient ready is their age, their gender, their surgical risk, their symptoms. Are they willing to participate in research? If they are they a good candidate? Do they live in another state? Do they have social support networks? Are they on oxygen? Are they on HD? Do they have a baseline arrhythmia? Is there a life-limiting diagnosis? And then you want to look, are your echo gradients demonstrating severe aortic stenosis? On your CT TAVR, what's your Agatston score? What's your annulus size, your height, your sinuses? What's your access? So when you've pulled all that information together and you're presenting it to your team, you by then already have enough information to make a good decision. And then that's where you get to your point of TAVI. So with TAVI, I always want to tell my patients why I'm selecting a certain valve for them. So when I tell a patient, hey, with the heart team met, we reviewed everything. We looked at all of your information. And the first thing we know is that your aortic valve needs to be replaced, because that some people, they need to hear that. They need to hear that they need a valve. And then I say, we have selected for you a valve that we feel is going to work best for you in your anatomy because of XYZ. And so then I will also point the patient to say, hey, I have a video on my vendor's website, or I have a picture that I can show you. A lot of our population even needs to see the valve. We do education and bring them in sometimes and do these TAVR classes, not only at the time of consult, but just as we're going along based on their individual needs. So while we're trying to streamline our processes and while we're trying to make sure we're decreasing variability, we're also treating individuals, and they're all going to have their individual needs. So, being able to go through and say, hey, I know this valve, I know this product, and the reason we picked it for you is, maybe it's the large cell design, or maybe it's their annulus size that we're trying to improve their EOA. Whatever it is, telling them why you've selected that device really makes a difference in their comfort level and their trust in the team. So then, it's important to mention that Dr. Cribier said we are far from the end of TAVR's odyssey, and the potential of this disruptive technology remains explosive. How true is that? There's so many things happening so fast, not only with TAVR, but in all of structural heart. But in TAVR specifically, there's several ongoing clinical trials. You have Envision for low and intermediate surgical risk patients. You have Envision valve and valve for those patients with a prosthetic valve. You have the Progress trial for patients with moderate aortic stenosis. I mean, so many things are in the pipeline that it is really something to stay on top of. And I think it's exciting to see what is next in structural heart. So thank you so much. I am going to pass it on to Sarah. She's going to go over some guidelines and STS score with you.
All right. Thank you, Martha. So let's talk about the guidelines and how we define high risk. Okay. So we're going to talk a little bit about the guidelines because I think they're important when you're talking about high risk stratification, how we make these decisions, how we collect the data to see if a patient's low risk, intermediate, high risk, STS scoring, and is that really important? How do we define that in the context of low, intermediate, and high risk? And then pulling it all together to really define the risk level of this patient. So my name is Sarah Kennedy. I'm a nurse practitioner and a valve clinic coordinator at Sentara Heart Hospital in Norfolk, Virginia. We have a fairly big hospital, a little over 600 beds. We have a 500 TAVR program. We do a lot of MitraClip. We do a lot of T-tier, all the structural heart procedures. Here's my team, pretty incredible team here. I'm going to dive into the guidelines first. So first is the D1. This is the severe aortic stenosis that we all think about, okay? Area less than 1, mean gradient greater than 40, peak gradient greater than 60, velocity greater than 400, okay? These are patients typically with normal EF, severe AS gradients. Not much we need to talk about that. We're all probably pretty familiar with those gradients. And then we get into low flow, low gradient aortic stenosis. And this is important because now we're starting to get into that higher risk population. These patients have reduced ejection fraction, which can make the procedure a little bit trickier. This can move patients into that higher risk category. And what does that mean? Low flow, low gradient aortic stenosis. So what that means is that ejection fraction, that LV, that ejection fraction is reduced. So when the LV pumps, it's a little bit dilated, a little bit weakened, so it can't create the amount of pressure that you would need to create the gradients that you would typically see in D1 aortic stenosis. So you can imagine if a patient with an EF of 60% has a mean gradient of 40, if you reduce that pump level so that EF is now 20%, it's going to be difficult to create that same amount of pressure to make a mean gradient of 40. So you're going to see lower gradients. You're going to see a mean gradient maybe in the 20s or the 30s. You're going to see a reduced Vmax of maybe in the 300s. And what's important about this is it's still severe aortic stenosis. It's still a life-threatening disease, and this patient still needs their valve fixed. But we have to figure out if it's a valve problem or if it's a muscle problem. And then my favorite is this paradoxical low flow, low gradient aortic stenosis. And I love this because I didn't even know what this was when I started this job. This really wasn't talked about a couple years ago, but it's absolutely a real thing. And these patients can be very high risk, especially related to TAVI. So paradoxical low flow, low gradient AS, you can see it's not a dilated muscle problem. These patients usually have a thickened LV. So you see, these little old ladies with hypertrophic cardiomyopathies and these really thick hearts. But what you see is that small LV cavity. So when the volume comes in and the volume goes out, it's usually a smaller amount of volume. So when it pumps, it doesn't create enough volume across the valve to create those same gradients. So this is when you see discordant gradients. And we all see this. We see these referrals where some of the gradients are severe, some of them are moderate, and we're not sure if we should treat this patient with TAVR or if they're ready yet. And I can tell you, since I've really learned about this and since I've taken a deeper dive, a lot of these patients that we've been following for moderate aortic stenosis that have symptoms or diastolic heart failure, but we really weren't treating them because we weren't saying it's severe. But now we do, CT scans, we look at calcium scores on the valve, and we do dobutamine stress test, and we do all of these testing to see if this really is aortic stenosis or not. And how do we make these decisions? Well, we all make them at our heart team discussion. Everyone has a different process for how they make these decisions. I've talked to a lot of coordinators. Some I hear are frustrated because they're made down the hall as the doctor and the coordinator are running down the hall and they're passing the cardiothoracic surgery surgeon and they're like, oh yeah, I saw Mr. Jones, he should have TAVR. And then some have these really well organized conferences where they all sit in the same room and they discuss the patients and they look at all the details. They're different everywhere, but this is really where we hone in on the risk level of that patient and what kind of valve we're going to choose for the patient. This isn't a lifetime management talk, but I think it's always important to discuss because when we choose this valve, we're very thoughtful because we're kind of starting that clock on the patient's valve disease and how we're going to treat it for their lifetime. But when we really take a deeper dive at life expectancy in the US and how many patients actually outlive their first valve, it's kind of shocking. And we absolutely, for these young patients who we're offering TAVI for, and especially in the low and intermediate risk, we really need to be thoughtful about this. But there's so many patients that we know are not going to outlive their valve. They need one good valve that's going to give them benefits for the next 10 years. Hopefully they live the 10 years and gives them the advantages that they need. And Martha touched on it. There's a lot of advantages of this Navitor valve that make it the right valve for the right patient. So let's talk about STS scoring. I can guarantee the majority of you on this phone as coordinators do not enjoy STS scoring. Maybe there's some of you that do. I do not carry that gene, okay? The STS scoring can be a lot. And you have to, when you're doing, 500 TAVRs, you do 1,000 STS scores a year. And, it is work and it is required for every TAVI. And I understand the importance of it, right? Because we have to have a basis of kind of comparison for these patients. And it needs to be documented, and we need that data to continue the field of structural heart. But it does not capture the true complexity and the true risk level of patients. So when we look at what makes a patient low risk, what makes a patient intermediate risk, and what makes a patient high risk, we typically say, kind of that 2 or 3 to 8% is in the intermediate risk, and then greater than 8 is clearly high risk, right? But if you've done enough STS scores, you understand that if you have a young patient that is better suited for TAVI and you want to offer TAVI, it is very difficult to get a high STS score, right? So when you look at what makes a patient high risk, they typically have comorbidities, heart disease, COPD, renal dysfunction. They've had prior surgeries. They may be older. They may be frailer. They may have reduced functional status. That's a large portion of our TAVI population, right? And when we look at this, I find it so interesting, and I'm very passionate about this because if you've done this long enough, when we started doing TAVI and when we were screening these patients 10 years ago before low risk was approved, we did all of this, right? We were having to prove that this patient is better served with a TAVR. So we were doing carotid PVLs, we were doing PFTs, we were combing the chart, looking at all of the comorbidities and documenting them in the chart. And how many doctors do you see, looking at wounds, looking for everything. And now we just don't have to do that. Most of us are, and we're still putting the work in, but we're not always capturing the true complexity of the patient, or at least getting the credit for it. And what I can say is, Martha made a really good point about billing and capturing your high-risk population. And I can't see the chat box right now, but I think there was a question posed right before I hopped on of what your percentage of high-risk patients is. And that's an interesting question because I commonly hear that, we just don't have high-risk patients. Oh, I'm not advancing. But high-risk patients, it's how you define it. And I really am asking you to kind of change your lens of how you evaluate these patients. So when we talk about risk level and what high risk means, this could mean significant comorbidities. So this could be an 85-year-old with heart failure. This could be someone with chronic kidney disease, pulmonary issues, or anyone that makes traditional surgery risky. That could be a high-risk patient. This other one, any patient who's not a candidate for open heart surgery can be labeled high risk. So this is an interesting point because, our surgeons are seeing all of these TAVR patients, and probably over 50% are being deemed non-bailout candidates or patients that would not be offered sternotomy in an emergency situation. If if we say that we would not offer a sternotomy, or in no way would we open this patient's chest, they're probably a high-risk patient. That automatically puts them in that group, no matter what their STS is. And when you're talking about risk level stratification and deeming someone high risk, the STS does not have to be 8%. It can be 3%, but the patient is deemed high risk by the heart team. Okay? And then let's talk about life expectancy. So we know every 65-year-old is not a 65-year-old, the same 65-year-old. So you have 65-year-olds that walk in, they've been playing pickleball, they feel good, they got a little short of breath. Yes, that patient is low risk. That patient would be well served with AVR or TAVR, depending on the circumstances and the anatomy, but that's a low risk patient. And then you have a 65-year-old who has lung cancer, came in a wheelchair, needs some kind of procedure for quality of life, and hopefully that cancer is treatable, but their life expectancy is likely not greater than 10 years, okay? You want to give them the best valve for the next 10 years of their life, okay? That patient, no matter how you do the STS score, it's going to be difficult to get 8%, but that is a high-risk patient. And then complex anatomical challenges, which Caitlin's going to kind of dive into. But how many of you are looking at CTs and kind of identifying high-risk anatomy? Okay. So big believer in patient-centered care. And what does that mean? It's a model in which providers partner with families to identify and satisfy the full range of patient needs and preferences. Because this is a discussion with patients. Patients are educated now. They come to you, they kind of know what they want. They've looked at these valves, they've done the research, their friend got one, they come educated, and we make these decisions together. And when we make these decisions, most of us are all talking about one sternotomy in the lifetime, if possible. Do we do TAVR now? Do we do SAVR next? Do we do SAVR now and TAVR next? But we're all kind of hoping that that patient only has to be cut open once. And so when we're opening up our eyes and changing our lenses and looking at this risk level stratification, we need to look at patient-specific considerations. So you might have a younger patient, or maybe someone in their 70s, and they have a cardiomyopathy. And they're still young, they're still pretty functional, but their EF is 20 or 30%, okay? That's still a high-risk operation. Maybe we offer them TAVI now, and if they have a great 10-year outcome, maybe there's a valve-in-valve option after that. We talked about anticipated life expectancy and what that really means, and then looking at other patient-specific considerations like pacemaker risk, coronary reaccess, what valve is best for that specific patient. So how do we evaluate risk level? So we review the medical history. We look at life expectancy, how many valve procedures are expected in their lifetime. Are they a good candidate for surgical aortic valve replacement? Do they have concomitant valve or coronary disease? And this is important because when you've done the STS score enough, you realize that there's AVR, there's MVR, there's AVR cabbage, there's MVR cabbage, there's no AVR, MVR cabbage, there's no AVR ascending aortic root because they have a tiny valve and they need that root enlarged. So you don't really capture the full complexity of the patient. And we have really forward-thinking surgeons here. And they say, if you can give me a valve in this patient that gives better hemodynamics than me having to open the chest and do an aortic valve with a root enlargement, then we're going to go the less invasive route. Looking at frailty, frailty is not required now for TAVI, but we do it fairly often. If you're a big research center, you're doing frailty testing. Do the eyeball test, okay? If the patient can't stand up and walk across the room, that should be documented. That should be taken into account when you're talking about risk level for these patients. The 5-meter walk is absolutely included and required for the registry. So if they can't complete that, then you might think high risk right away. Albumin levels, malnutrition is something we can check if we're looking at our true complexity of risk level. And then home oxygen. If your patient's on home oxygen, they're automatically high risk. So here's an example of frailty. It's not required anymore, except for some research studies, but is it helpful? Yes, I think if you're trying to look at your real risk stratification of how many high-risk patients do I have, frailty could be helpful. And then looking at your KCCQ and your 5-meter walks. This is a nice slide regarding the CTA of the chest, abdomen, pelvis, and what we look at for high-risk kind of stratification. So when we're looking at that valve and we're looking at the annulus of the valve, and you see that huge chunk of calcium coming down, that's a high-risk feature for a patient. When you're looking at the peripherals and you're looking at arterial disease and you're thinking this patient might need alternate access TAVR, that's a high-risk patient. So we talked a little bit about STS, but some of you may do this, some of you may not. But when you see this first box and you drop down to elective, urgent, emergent salvage, we always include in our slides this emergent salvage. And what that does is it kind of tells us if we have a patient that's, intermediate or high risk, and we're kind of deciding what valve we want, or we're talking about what real risk level this patient is, we look at also emergent salvage. So yes, I could do a AVR, yes, I could do a TAVR, but if I have to do an emergent sternotomy on the table to bail this patient out, what is the risk of that? And kind of looking at the full risk level of the patient, because we know a planned surgical AVR is not the same as a bailout on the table. So I've just included a couple examples, and these are just real life examples that we deal with very commonly. So this is a 79-year-old, BMI is 42, class 3 heart failure. Patients have progressive shortness of breath, dyspnea on exertion, and presyncope. Severe aortic stenosis, had a prior balloon valvuloplasty. She's had a VSD that she's had forever. She has non-obstructive coronary disease. She's got AFib, but preserved EF. She's got severe bilateral carotid disease and need a vascular intervention prior to TAVI, type 2 diabetes, hypertension, hyperlipidemia. You look at her labs, and they're all fairly unremarkable, nothing too crazy there. We do look at the EKG to look at pacemaker risk because that helps us with valve selection. We still do dental at Norfolk. So we're looking at her echocardiogram. She has classic D1 aortic stenosis. Her Vmax is 450, mean gradient 51, area 0.5. And then cardiac cath, non-obstructive coronary disease. So we look at her iliofemorals and we can see they are calcified and they're small. And then we look at her roadmap to TAVR, and her area is 414, perimeter 76, adequate coronary heights, over 10 is kind of what we're looking at, adequate sinuses, and this is a picture of that VSD. So then we look at STS score. This patient, 79 years old, with comorbidities, significant peripheral arterial disease, needs carotid surgery, has an STS of 3%, okay? Nowhere near that high-risk STS score. And so the surgeon sees her, and he's like, no way in the world would I offer this patient SAVR, okay? Why? Because she's high risk. She has significant peripheral arterial disease. She has a VSD. She has some coronary disease. It would be difficult to get her through an open heart surgery. So ultimately, she's a good TAVR candidate. And I think it has, sorry, I'm not advancing. There we go. So this is kind of just a breakdown of how we came to that. And when you think about valve selection, so you have a high-risk patient, and you can choose any platform, right? So Edwards and Evolut, we do a lot of all of them. Edwards and Evolut, low risk, approved, intermediate, high, use it if you want. But right now, Navitor is just high risk. So when we're looking at all those, we want the valve that provides easy coronary reaccess, an easily deliverable sheath because of her significant peripheral arterial disease. And this woman's probably only going to need one valve in a lifetime. So with her, we chose a Navitor. And then here's another example. And I guess I should have kind of prefaced this. This is how we do our heart team discussion. Our APPs, we have 7 APPs. They are all trained to do CT analysis. So we put this together for our heart team discussions. And what this does is this allows us to kind of facilitate quick discussions that look at all of the pertinent data that we would want to make an informed decision regarding risk level and valve selection for this patient. So this is patient B. Patient B is an 85-year-old male. He has a BMI of 23, came in with heart failure exacerbation. So when you look at his past medical history, it's not very long, right? So this is probably 85-year-old. He's been to the doctor 3 times, doesn't need doctors. You know, he's been diagnosed with critical IS, dilated cardiomyopathy because he didn't go to the doctor, and now he knows he has coronary disease and critical IS, and came in with CHF exacerbation. His labs are all pretty good. He does have a left bundle branch block, okay? And he had his teeth removed for the TAVR. And then we look at his echo, and his numbers are a little bit discordant, or what you would say are not typical for that D1 stenosis. He's got a EF of 30%, area of 0.5, mean gradient of 21, Vmax of 320, and reduced dimensionless index, and also moderate MR. So if you took him to the OR, now you're looking at a patient with an EF of 30%, concomitant mitral disease, and severe critical aortic stenosis, okay? High risk off the bat. And then you get his cath results. And he also has LAD disease and RCA disease. So now, CABG, AVR, MVR, okay? Access looks fantastic because he's running a marathon and not going to the doctor. Roadmap is pretty good for all valve platforms. And his STS comes out to 16%. So that's a clear high-risk patient. You could use any valve platform for him. Okay. So what makes him a high-risk patient? Cardiomyopathy, coronary artery disease. So when I talk about this, you know, people ask me, they're like, I just don't find those high-risk patients. But we are taking care of high-risk patients. The majority of our TAVR patients are older, they're frailer, they're wheelchair bound, they can't walk very far. You know, their life expectancy is not more than 10 years, okay? Their med list is this long. They have 7 doctors that they're seeing. But we do our STS score and it's low. Or they get up and they can't walk across the room. You know, they don't really pass the eyeball test. We can get them through a TAVR, but we want to make sure we're offering the right valve for that patient based on patient-specific considerations. So I'm going to leave you with this. I say success is often hidden in the smallest details. It's the careful attention to the overlooked that turns good work into greatness. And I know we're all very detail oriented, and I know we're all investigator detectives that love to find these details. So I challenge you to kind of open your eyes, change your lens, and take credit for the complexity and the risk level that you're actually treating every day with these TAVR patients. So if there's any questions, any quick questions, Caitlin or Martha, if you want to open up, I'd be happy to chat real quick. And then I want to pass it on to Caitlin, who has a great case to share with you about complex anatomy, and is going to share some insight regarding echoes and what we look at for these patients.
Thank you, Sarah. That was awesome. 2 things that, I couldn't agree more. Sometimes when you see these patients and you walk into the room and you think surgery, and then you walk in because they have that low STS, you walk in and they can't get up and you think, oh goodness, you're changing your script a lot, right? So I think that's, you have to be on your toes and you have to have your data there. The other thing we have found is, just like everybody else, our valve team meetings last 2+ hours, right? So we did come up with something just in the past year or so, where these guidelines where we made for our own team, where if we are leave the room and we've had sort of a heart team meeting, we have a cardiac surgeon, an interventional cardiologist, myself, a valve coordinator, an echo person. We all go in together to see these patients. We're very lucky that we have that. But we sort of had our valve team meeting. And if it's a low risk patient and it's very straightforward and we've made our valve choice, we declare that person heart team approved. And we have these guidelines that we've set, and I'm happy to share those with anybody, but it has cut down our heart team meetings quite a bit. You know, we're able to now only discuss our high risk, complicated cases, not sure what valve to pick patients. So it has really helped. I don't know if anybody else has sort of come up with any guidelines like that or found ways to sort of manage these heart team meetings, because it's a lot of work to prepare these patients for presentation, and they take time to go over. So I'd love, you know, if anybody has any other thoughts, I'd love to hear it.
I agree with kind of the guidelines. That has helped us immensely to just say, hey, these patients are very straightforward. You know, we can move on and just really spend our time focusing on those more challenging anatomies.
Perfect. I don't know if there are questions there, Tiffany. Are we okay to keep going, or do you want? Are there any questions you want to bring up now?
We have one question to share guidelines. I know what, maybe we save that for the end so that
Sure.
Caitlin, you can give your presentation. And then I think there's 2 questions in the chat we can do then.
Sure, that sounds great. Perfect. All right, we'll keep rolling here. So just to sort of piggyback off of Sarah, those are great cases. And, you know, really it's difficult to sort of go through these cases. And it's nice as an APP and a valve clinic coordinator to be able to take the time to do this. We don't really always have the time to sit and do that. As everybody said, my name is Caitlin Reen. I am the lead advanced practice provider for our heart team here at Mass General Hospital in Boston. We are about a 550 TAVR program a year. We are pretty busy. We do all the other things too, mitrals and tricuspids and all the things. I was the only APP for our team until October 1st of this year. We have finally got another APP. So the volume has been an issue, right? And keeping all this together has been tricky, and finding ways to really take the time to expand your knowledge and give yourself a little bit of grace to sit down and say, I really need some help with this. I really want to learn more about echo. Can you help me with the imaging? You know, that was something that I didn't really have time to do because I was managing 550 TAVRs a year. So we're going to talk a little bit about that at the end, about how you can really sort of draw the line in the sand and say, I need some education. I want to sort of promote myself a little bit more. So we're going to get to that. So let's go over a little bit of a complicated case here first. So a little bit of a clinical vignette. This is a 92-year-old female. She came to us as the Pilates instructor in her assisted living. So she said she was getting a little bit more short of breath while she was teaching her classes. You know, past medical history has hypertension, hyperlipidemia. She had breast cancer with chemo and radiation. Her aortic stenosis has a mean gradient of 45. She has a normal sinus rhythm, a little bit of a prolonged PR on her EKG. Again, those symptoms were just this effort, exercise intolerance. She just wasn't able to sort of get that oomph that she wanted to get when she was teaching her Pilates classes. So, you know, we take a peek at this here, and we often, you know, sort of get a big picture of the patient. And the procedural plan for this challenging case was for a 25 Navitor. You see that LVOT taper to about 66. The measurements aren't here. They're going to come in on the next slide. You know, your sinuses and your coronary heights are okay. We were thinking right femoral access with sort of adequate vessel caliber there. And the plan was made for an 18 BAV prior to the case. So, you know, you can see in these images sort of that those sharp angles and that tortuosity of the anatomy. So not a straightforward case, okay? So when we do sort of this pre-procedural planning, the case evaluation noted a couple of things here. You can see on this plan. The CT noted that the 25 Navitor would be the best suited for the anatomy. There is heavy leaflet calcium. There's calcium everywhere. You're going to see that in a couple minutes. So the formal rec for that pre-BAV for all patients was sort of derived from that measurement of the minimal diameter. And the root angle here was thought to be about 80 degrees with that extreme tortuosity and presence of a horizontal root. So, you know, the vascular anatomy was tortuous at the bilateral common iliacs. There was presence of circumferential calcium in the distal aorta. So, you know, not pretty, but doable, right? So we do look at these measurements, and a couple of things to note here. So that eccentric heavy calcification at the annulus there. We know we worry about the placement of that calcium. Sarah showed one with that chunk of calcium right there, because that increases the risk for a PVL, right? It prevents that lack of a true seal to get that valve in there and really seal it off. We caution the use of a balloon expandable that you would, injure the annulus there at that site of a heavy calcification. So for pre-procedural planning here, we want to prepare to not only navigate that sort of hazardous anatomy, but given the calcium, it wasn't really a slam dunk as to what we were going to do here and how this was going to behave. So we look also here at the ascending aorta diameters. They are on the larger side here, but our team thought that given the age of the patient, probably unlikely that we would need to intervene there. And then the other thing, and we circled it here on the perimeter, you can see that sort of oval shape of the annulus is measured at like 19 by 26. So a lot of quirky things here and a lot of things that it wasn't straightforward. This was not a case we approved at the end of our clinic. This is a case we absolutely brought to our joint clinic, heart team meeting, and sort of, went through it step by step. And I love that Sarah showed that sort of slide where how they presented at their meeting. We do the exact same thing. Our fellows present our cases and prep our slides, and we have our images of our CT and we have our images of our echo pulled up and queued up for anybody that hasn't known the case so that they, we can really get a true group consensus, and everything is there. All that data is presented at the same time. So we see here that STJ, right, is high in relation to the aortic annulus. It's large in diameter. The coronaries are high. So thankfully the risk for coronary occlusion remains low. That was one thing that we were like, okay, we'll take the win. That horizontal aorta, again, you're seeing there, that angle we thought was about 80 degrees, maybe sort of pre-procedure. And, always we know that increases the risk for asymmetric deployment. And then because of that asymmetric deployment, meaning it doesn't sort of meet it's not going to seal as well, that increases the risk for your PVL. And that's not something we want to see. So, despite the vessels being completely tortuous and sort of hard to navigate, they are ample size and they are acceptable for large bore access. So we'll take that win as well. So, this tortuous vessel, it's ugly, right? And we take a peek at these and we're doing the measurements. You can actually see here, we have about 2 90-degree turns here. There's one of that descending, and then you sort of see the other one at the arch. So this was a big discussion of, what valve do we use here? What system do we use here to navigate this? So when we come back, with this lights up like a Christmas tree, you see the calcium is everywhere. It's hazardous. It is a minefield in there. That is something that we need to really be prepared to take on and to navigate. So, at the previously noted, the vessels were large, they have low bifes, we're able to get what we need to get up there. So what we decided to sort of pull it all together as a pre-evaluation plan was we were going to do a 25 Navitor. We were going to do, so noting that LVO taper at 66, the sinuses are okay, the coronary heights are okay. We were going to do a right femoral access, the vessels were adequate in caliber, and sort of an 18 millimeter pre-VAV. So you take a peek here, you can really appreciate the tortuosity of that vessel there. There are twists and turns. So the concern here from our team was what we call the pushability of the ability to advance the system through these vessels. So, when you're trying to do that and it's very torqued and twisty, all the torque builds up in the delivery system. So you have to be careful and make sure you have a stable landing zone there so that you would landing the valve where you want to put it. So, when we are explaining these to our patients and we're showing videos and we're explaining them, we show them that we are able to sort of move the valve around and make sure that we stick the landing. That's where we want it to be. And so when we decided to do it in this case, we did use a Lunderquist wile, which is not usually used with a Navitor. But due to that tortuosity in the abdominal aorta and that challenging anatomy, we just thought the Lundy was the best choice. The external sheath was used to straighten out the aorta. As you can see, it sort of helped us navigate, and having that pre-case plan was so important here because we were prepared when we were in. I think if you sort of breeze through these and have that meeting in the hallway where everybody's like, yeah, fine, TAVR, let's go. I think you miss these critical things and you have to be prepared as a team when you walk in there. So this was an important one for us to discuss. The pigtail, we're navigating depth with that. Again, making sure that we are sticking the landing. What we did here And what we usually do for an aorta that is that tortuous is we either use a radial access as our second access to avoid having to navigate the aorta twice, or use sort of a contralateral femoral second Lundy or something inside a pigtail to straighten out that aorta to help us navigate. So just sort of some technical things we usually do here when we're seeing these kinds of cases. Here you see that injection on the contralateral side, just to protect the access site. And then, you know, that aorta, so our pre-planning aorta angle was about 80 degrees. When we were in there, it was actually noted to be almost a 90-degree angle. So, you know, you can see here it's sort of coaxial or central in the aorta. Our team did have to recapture once and then partially recapture once. You know, we did have a teaching moment here that when you have that deeper horizontal anatomy, you have to really start a little bit deeper. So you have to start deeper, and we knew that given the horizontal anatomy, which let us capture that left coronary cusp a little bit better. You know, and using the Lundy, which again is not usually something we do with Navitor, it just did help us increase. You know, your risk of using it is that it's increase of its rigidity. So you have to be careful for perforation. So the final deployment, gratefully, it looked great. Our pre-BAV balloon was 18. We did plan for a deeper start of that deployment due to that horizontal angle. The delivery was smooth. It was stable. Our ending depth was about 3 on that non-coronary cusp and 6 on the left. We did use the sort of those calcium markers on the topmost part of the valve to assure and to note that solid annular contact to make sure that we were really capturing and landing where we wanted to land. Final gradient was about 11, no leak, which was fantastic. She did develop a left bundle post-procedure, but it did resolve pretty quickly before she went home. So you can see that looks pretty great there. And you know, using the Navitor was really the way forward. So procedural challenges, you can find anything in there, the calcium, the horizontal annulus, you know, those 90-degree turns, the tortual aorta. There's so many things that you can find there, and having a pre-procedural plan that is agreed upon by your whole team, right? So, you know, you can't have these conversations in the hallway and say, let's wing it and go for it. This needs to be something that's documented and discussed with your team. And I think that's important. Here, the patient recovered well. She was discharged home to her assisted living on post-procedure day 1. At her 30-day follow-up, she improved with her exercise capacity. Her breathing improved. We did ask her not to return to Pilates, but she did show up in a full Lululemon outfit at 92, planning to teach her regularly scheduled class the following week. So she did great. So changing gears just a little bit, you know, I led this off saying as APPs and VCCs, we don't have a lot of time for anything, but certainly not a lot of time to really work on things that can advance our knowledge and broaden our knowledge base. So I call what we do care traffic control, and it's like we're navigating 400 things during the day, and you know, we don't really have time to sit and work on ourselves and advance our own knowledge. So couple of things to review. You know, we are all very aware of the ASC guidelines here and the parameters that we follow when we're evaluating and screening these patients. But, you know, I think it's important to know that not everybody is aware of these guidelines. When we're seeing patients that are either referred too late or referred too early, we were noting that the education was needed in our referring areas. So we made it a point to go out to our local teams, to our primary care offices and our general cardiology practices to review these classifications and review the guidelines. It's not their job to know the change. These change all the time. It's not their job to keep up with it. It's not their job to understand the new data that's come out. That is something that I think we should own. And we did go out and do a lot of education for this, and it changed our referral patterns in a good way. We were getting patients that were on fire, and then we were getting patients that had mild AS. So, you know, it was really important for us to go out and navigate what was the knowledge base around us and when is it appropriate to send a patient. We always say when in doubt, send them. We'll absolutely see them. We do have an APP run clinic where I am that sort of takes care of those mild to moderate asymptomatic patients, which is great. They get them in with the heart team and they're sort of in our window and we know about them. But, you know, internally, it was a discussion that we had to make. How do we teach the teams that are referring to us, these legacy providers that have known these teams forever, that just see, you know, oh, a little bit of aortic stenosis, oh, we have to send them to the team. So the volume you have to manage, and you have to be able to educate your patients and your patients' providers. So when we're seeing mixed gradings in a lot of our outside echoes, we would take a peek at the outside imaging and maybe say, oh, it doesn't really look severe. Let's do an overread here. And we find it to be mild to moderate. So, you know, being able to have a discussion with your patients to say, we're going to use all the information we can that you come to us with. If you come to us with 4 echoes, a TEE, and a CT, great. We're going to take a peek at all of that. But if we're the team that you choose to do this with, there's a chance we might have to repeat something just because we're going to be the ones doing the procedure. We have to trust our data and everything like that. So we do have those discussions with our patients and sort of in that introductory phone call say, we will take what you have. But if we find the need as a team to repeat something, we will. And patients are usually understandable for that. You know, just as a question, is anybody else doing that? Does anybody use any of the outside data and or do you repeat everything? Do you start from scratch? I'd love to hear what teams are doing.
We're certainly using all of the outside data. And even if you can get a small portion of it, maybe you can just do a limited or something like that.
Absolutely.
So yeah, so we're certainly using everything that they come with. And then if we do have to repeat it, then we do the same thing you do, saying, hey, you know, your provider did a great job getting you here to us,
Right.
but we may need to just get a little bit of a different look.
Same for us.
Yeah, I think it's, you know, and it's been helpful. We've used sort of these opportunities to go to our local teams and say, we'd love you to be involved with this patient and we'd love you to be their legacy provider, right? But if you could get this, and this to us prior to them coming, very helpful. We're going to be able to, you know, sort of expedite their evaluation. Some of our providers still do PFTs. Some of our providers still get carotids. If you want to get those done before they come to us, great. That sounds awesome. You know, we're going to see them a little bit faster. We'll get them done faster. So, you know, being able to use these guidelines and educate your local teams is really important. And I think it's something that we own. Not that we have time to own these things, but, you know, sometimes it's important for us to take these on. So when we see these things, you know, this stepwise approach is helpful to guide our decisions. It keeps in mind the goals. You know, we're sort of establishing a diagnosis, defining the cause, you know, understanding the level of obstruction, quantifying severity, evaluating for coexisting valvular disease, assessing that LV function. You know, this whole picture wraps up sort of towards a procedural plan for a patient. And, you know, sharing this slide, this simple slide with our referring providers is always helpful. They're always asking, how did you get to that plan? You know, what was the approach? Why did you do this one for this one and this for that? So we go through this with them. And when we present these cases in our heart team meeting, we send them our one-liner, if you will, about why we came to our decision. We are overachievers when it comes to keeping our referring providers in the loop. In the first talk with Martha, it was how do you keep your patients organized and make sure everybody's doing it the same way? Extremely important points. A point to add to that is make sure it's visible to everyone. Make sure that it's not you guys having a notebook in your office that only the valve clinic coordinators can see. Make sure that it's something digital in real time that your referring provider can log on to Epic or whatever platform you have and say, I referred this patient a month ago. I wonder where they are. Have they had anything done? Oh, their CT is done. Oh, you know, so they're able to see this. Anything that's visible to keep your whole team in the loop selfishly cuts down on the phone calls to you to say, hey, Kate, referred the patient a month ago, you know, where do they stand, when they can just themselves log in and take a peek. So, you know, another way to sort of keep that halo effect open and that open communication is great. We spend a lot of time educating our primary care practices on this. And sort of making sure that they're up to date with all the guidelines and all of the data that's there. I think a very important thing and a first step in becoming confident with your imaging skills is to know what you're looking at. What angle are we looking at it? What valve are we looking at? What do the red and blue mean? Like, this is how basic we get when we get a new valve clinic coordinator, when we get a new fellow, when we get a new interventional cardiologist, we sit and we go through things like this. You know, I work at a teaching facility, so we're very lucky to sit and have time to talk about every case and look at every picture and go through every image together. We have 2 structural heart fellows that are required to go through these images for our heart team every time. So it's repetitive, and that's how we've learned it. You know, I think when we sit with our interventional cardiologist and our surgeon in valve clinic, these are breezed through, right? And now that we're bringing in, you know, image specialists to our valve teams and, you know, sometimes EP specialists, sometimes heart failure specialists, we do take the time to go through these. And I think it's really important for your skill set to understand the difference. Understand the difference of what a TTE looks like, what a TEE is looking at. Also, what your valve is, just from a basic anatomy standpoint. What is the type of aortic stenosis we're talking about? Is it a normal? Is it a rheumatic? Is it a bicuspid? Is it a calcified valve? What are we looking at here? It does help. And you know what? Your patients love to see this. Our patients love 2 things, 3 things. They love anything they can hold. So any sort of anatomy, any sort of model that you can show them, they love. 2, they love paper, anything. So we send them a folder before they come, a welcome to our clinic with a folder of our faces. They love to see who they're going to meet and what testing they're going to have and what their evaluation is going to look like. And when you have them in clinic, we show them their pictures. We go through a video of how we're going to do this TAVR for them, what their actual heart looks like. They'll always say, oh my goodness, that's mine. You know, they're fascinated by this. It's a very hard thing to imagine when, you know, we do this 550 times a year. But when you have a new patient coming in who doesn't really understand it, to be able to see it on the screen and understand their anatomy and how we're going to get that valve there, it's really important. I think as, you know, we're also lucky to have our own dedicated structural heart echocardiographers and imagers at Mass General. We spend a lot of time with our fellows, and the fellows in turn spend a lot of time with us as APPs and valve clinic coordinators, helping us orient ourselves. When we put together our screens and our shots for our heart team meeting, we include these views on our little slide. We use the 2D axis here. We use the systole and diastole. We use the 2D short axis view. We sort of put the number of where the severe aortic stenosis is on the bottom of the screen. In case there's a new echocardiographer that happens to pop in for heart team meeting, we know exactly where to go, what we're looking at here. You know, we spend a lot of time looking at these, but we carve it out. We were finding that things were happening too fast, and I wanted to be knowledgeable and feel confident in my imaging understanding. You know, not understanding that it's not my job to read the echo, but it is my job to understand the echo. And also, when we're screening these patients, what I'm now able to take a peek at an outside echo and say, suboptimal, you know, we really need to repeat this. It didn't get the shots that we need. We're missing that 5-chamber view. You know, the substernal view is not great. We're not really seeing what we need to see. So, you know, it really does cement that you have a seat at this table and you're valuing yourself, that you understand this anatomic evaluation. So we use these things here to really look at a couple of things. So the combination of that short and long axis, we look at the number of leaflets. We look at the degree of mobility, the degree of thickness, how much calcium is there. The combination of the imaging and the Doppler allows us to determine the level of obstruction. Where is the obstruction? Is it subvalvular, valvular, supravalvular? And then, you know, we always have that discussion with our patient. You know, we don't always get a TEE on our AS patients. Sometimes it's necessary. And sometimes that's a discussion that you have to have with your patient, saying, we have to move to a little bit more of an invasive evaluation here, just to make sure we're seeing what we have. Sometimes with that concomitant valve disease, when you're taking a peek at the mitral and tricuspid at the same time, a TEE is important to have. So as APPs, VCCs, you know, the things that what do we need to ask? I will say the number one thing to do is get to know your sonographers, get to know who is that champion for you in your echo lab? Who is the person that you can call and say, hey, can you walk me through this? I'm not really understanding these numbers. Or, hey, can I pop down to the reading room just so you can kind of walk me through this and see let me see what you see. I like how Sarah says, change your lens. Like sometimes I sit in these conferences and I sit there as an APP and I have 20 things running through my brain. I like that she framed it as change your lens. Think of yourself as the sonographer. What are we looking at here? Why is this valuable? Why do I need to know this? What's missing from this report, right? So when we look at these reports, you know, what is the etiology? Is it rheumatic? Is it bicuspid? Is there a subvalvular membrane? Is it supravalvular? Did we look at all the valves? You know, we were getting one referring practice who was sending us limited TTEs, only looking at the aortic valve. And we were like, super helpful, but like, what about everything else? So like, I caution using the limited from outside teams, because it's like, well, what if there's severe MR? What if there's severe torrential TR? There's other things that we need to take a peek at. You know, is this adequate for our heart team? Do you feel comfortable using this to plan a safe procedure? And I would say 90% of the time we do. And if we just think that maybe there's something else we need to take a greater peek at, we'll repeat it, and that's okay. We're looking at those gradients. Are they high? Are they low? What's the calcium? What's the calcium score? If yes, where is it? Is it that big chunk that we're worried about? Do we need to talk about, you know, perforation and things like that, and bailouts and all of that? We know that we're looking at the EF, and we know that your TTE gives you a more accurate EF than your TEE. So because our brains are busy and we have zero time to do anything else or remember anything else, these guidelines and these apps are amazing. We do use these for our new fellows that come in and our new APP, and some of our valve clinic coordinators. We do take a peek at these, and we use these in clinic to say, what does this actually look like? Well, you know, we'll enter in the patient's data. It helps us really go forward. I'd be interested to know if anybody uses these. You can just raise your hand or say in the chat that we find these helpful or we don't find them helpful. But I will say it's nice to have them on hand in case you do need to use them. So wrapping up, you do have a seat at the imaging table. I am a staunch proponent that all APPs and VCCs have a prominent seat at our heart table, but I dare say that we have a seat at the imaging table as well. We are looking at these images just as much as our interventional team is, just as much as the surgical team is. You know, and you have to be conscious of what you're looking at and confident in what you're looking at. I love that Sarah's team has APPs that present these at Heart Team. I think that's amazing. You know, I think that we should all be able to feel confident to do that, and we should feel that, you know, we have the knowledge base to do so. Ways to do that, it has to be individualized. Can you meet with your interventional cardiologist? Can you meet with your structural heart echocardiographers? Can you follow them for a day? Can you sit with them, go to their echo conference? Our team has an echo conference bi-monthly that they go over hard cases. They go over basic cases. We're able to sit in on those and really understand what they're looking at, look through things through their lens. And I really appreciate, again, Sarah, I'm stealing that from you. And again, you know, trust yourself. I think you know more than you think you do. And just be confident in it, and understand that there's always more to learn. Know where you can find it and know who your champion is there. And you know, certainly use it to advance your knowledge. So thanks, guys.
Thank you so much to all my three wonderful speakers. And Caitlin, I love how you're talking about you have a seat at the table. I think that is so true. I think it's important to advocate yourself in everything that you do. And if there is an opportunity for you to learn something new, I think it's a great chance for you to take that and ask questions. Speaking of questions, we did get some questions in the chat that I would like to address. And if you have any questions that are lingering, feel free to type it in. We are going to make sure that we get to as many questions as we can. Let me scroll through. Some of these questions were submitted directly to us, so I wanted to make sure we got to everyone. One person had asked, so the STS and doctor clinic of the low, medium, moderate doesn't matter as long as there's one documented. I think this is related to your presentation, Sarah, on the STS score. I did see that Martha replied saying that the STS score matters, but may not capture the full picture. That's where the eyeball test comes in. The heart team may rate the patient high risk, even if the patient is a lower STS score. Sarah, did you want to add anything to that?
No, I think that's perfect. I think it's just capturing the full complexity of the patient and not just looking at one number when you're doing risk stratification.
I think also important is if you have a clinic where you're not going in as a team, right? So I always find it interesting if the surgeon sees someone and then the interventionist sees someone, and then I look at those notes and sometimes they're different. I think, what, did we see the same patient? You know, you always wonder like, what happened here? So, you know, and maybe making sure that conversation happens to understand where did you see that? Or I just eyeballed it and I changed it, you know? So like having those conversations is so important.
Thank you. And then the next question was from, can you please share your guidelines? I think this was around doing the stratification. And I think maybe Sarah and Martha had answered this. Caitlin, do you want to provide any insight to what you guys do?
I'm not sure if it meant the guidelines that we made for our heart team meeting. I'm not, maybe that's what they were talking about. So I'm absolutely happy to share them. I will say it's very specific to us. Use them as sort of a framework. Use them to say, you know, I mean, it gets very detailed. So if they don't hit one of those things, then we talk about them in our meeting, but I'm happy to share. I've shared it at other national meetings, and it's really, people have come back and said our 2.5 hour, meeting is now an hour, and it's great. And we know everybody is sort of on the same page. So use them as a framework and bring them to your team to say, how about if we use this to sort of approve the low risk patients, and we talk about the more difficult ones in meeting. Absolutely happy to share.
Thank you so much. Okay. And then this next question was asked to us, and then I know the other two responded. So let me just read it, and then I'll read the responses. So how do you get providers to fit heart team review when everyone is so busy? Martha had put in the chat, for our program, we have a weekly set meeting prior to case start times. We review aortic one day and mitral tricuspid another day. We've been using WebEx for these meetings for the last few years, and it's really helped them save and more. It's really helped have more involvement and increased number of patients we're able to view. Sarah had said, we also have set times each week, Monday, 7 to 8 a.m., where they review 20 patients. All docs are invited, but as long as there's an IC and CTS representations, decisions can be made. There is a team option so that I think advanced heart failure EP referrings can also be included. Caitlin, do you want to add anything to this?
Yeah, sorry, I missed that one. So 2 things. I think incentives work really well. So we got CEUs for people to come to our heart team meeting. So that helps, number 1. And number 2, we do invite our referring providers. So, that gets tricky sometimes, but we'll say, we have PCP who's referred 4 people, we're going to do their patients first. And we kind of go through that, and their feedback is always amazing. And, we try to do these as fast as we can. We try to prepare them. We have a set aortic meeting and a set mitral and tricuspid meeting. Each one is technically an hour, but that's the goal each week.
Awesome, thank you. And then another question in the chat, is it possible we could have a copy of the slides or the recording to refer back to? Yes, this webinar is being recorded. We will make the recording available after. Today, it'll come through your Abbott representative, and we'll also post it online so that you can view it at your leisure. The last question I have, it says from the group, so we might have a watch party. What is your method for patient tracking? So Martha, why don't you go first, and then we'll have Sarah and then Kate answer the question.
Sure. So we have a patient tracking software called ValveTrack, but we kind of do a hybrid approach because we also use Epic lists to keep track of some of our patient groups that we're really focusing on, especially for our research studies and things like that. So it's somewhat of a hybrid, but our main patient tracking software is ValveTrack.
I love that. I'll have to look into that. We also have kind of a hybrid approach. We use Epic for a lot of it, and then we also have the Excel spreadsheet. Can't get away from it.
I see that face. I know. So when we took this this sort of program over from the valve clinic coordinator before, she would walk around with this magical notebook. She was the only one, and like nobody knew what was in the notebook besides her. And she was the only one that could see it, but everything was in there. So we were like, that's not going to work. So we had to sort of digitize it a little bit, just modernize the engine, if you will. So we use Epic as well. Epic is not great for everything, but we are working on sort of a structural heart platform in Epic. So it keeps the whole team involved. Everything is visible. And I mentioned that earlier, anything that you can do to make your life easier, right? So make sure using this thing that everybody can see, it cuts down on the phone calls you're getting from these referring providers. It cuts down on the patient phone calls. It cuts down on everything. They can see where they are in the workup. Your referring team can see where they are in the workup. So that's what we use. We don't use the hidden golden notebook anymore, but the Excel spreadsheet, I think if it works, it works. I just think if everybody has access to it, and if you are allowed to go on a vacation, make sure somebody knows how to work it and you're all on the same page. I think Martha made a good point. It has to be consistent.
Thank you. I almost want to say, what is a vacation? But I think you guys all affiliate. There was a comment in the chat, and I'm thinking maybe we can give some advice. So I'm an STS C Corp and TAVR coordinator, and I also have to pair the STEMI data. Now they want to add the Watchman, or let's just say LAO, and want me to be the coordinator for that registry as well. I can't manage it all. Do we have maybe some advice that we could give?
Yeah, take a vacation. Besides, so we are lucky to have a dedicated person that is a full-time job, but it is overwhelming. And it is, if anybody has done these abstractions, each one of these takes an hour at least to do. A lot of teams I found are moving these to the quality department. So, really sort of taking it out of cardiology and moving it to your quality department is something to look into if that's an option. I'm sorry that they keep adding this. I will say, I find that if people don't do their job well, they get someone to help them do their job. But if you're doing your job well, you get more jobs. So you must be doing a really good job. But I don't know, try to see if you can get someone to help you there. That's a lot of data.
I would agree with you, Kayla. A lot of our stuff's been moved to quality. That's the data abstraction. I can also say that, you can work with people to do some type of like a financial analysis for your program, really show where you can be best utilized to the highest level your license can take you. And then let somebody, a data abstractor pull data or things like that. There's ways to show with the halo effect that you guys mentioned earlier. Hey, we're doing this, 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 and this. And, it's impossible for me to effectively manage all of it.
Yeah, I echo what all of you said. We have moved most of ours to quality. And the way we did that is kind of identifying what's really a hospital initiative and what affects, hospital outcomes and how we look as a hospital, and what's inside program on the grounds requirement. And we need that TAVI coordinator. We need that Watchman coordinator, but we don't need them putting in all the STS database numbers. Okay, we need them coordinating these patient procedures. So that's kind of how we worked around it.
Martha, I love that you said, use it to sort of make sure everybody's doing what they should be doing. Another thing, we kind of flipped it and we said, because we're doing so much of this, we're not able to do this. So we're not able to advance our program. We're not able to go out and educate. We're not able to, we flipped it a little bit and said, if we had this person to manage this, as APPs, we're now able to do things that an APP should be doing, right? Or a VCC should be doing. So use that both ways. There's something called a SWOT analysis that we did for our program as well. Strength, weaknesses, opportunities, and threats. If you can put that together and you have a 30-second elevator ride with your chief of cardiology, these are things you have to have ready and really be ready to sort of advocate for your program.
Thank you so much. It looks like we have another question. I noticed valve EOAs from all three vendors on Sarah's examples. Is this something always being considered by the heart team?
Well, it is for us. So I'll let Caitlin and Martha kind of take that over.
Sarah, I actually took a picture of your slide because I thought that was awesome. We don't do that. We sort of have a discussion about it, but I love that you prepare it and it's there for open discussion. I think that was amazing. And I sneakily took a little picture. So we're going to steal that from you, Sarah.
I can send you a blank copy.
Okay, thanks.
Agree. I think that for us, we're pulling up, we're giving a verbal presentation of all their history and then pulling up their 3 Mencio and kind of scrolling through it. So I really love that one pager that gives all the pertinent data. I also want that blank copy.
You got it.
It's handy too, because our fellows then use it for the huddle when we go in for procedure. So it's not sort of wasted energy and it takes a lot of time to put that together. And then we use it again for our pre-procedure huddle and we use it to send to our referring provider. So it is a great snapshot to keep.
And hemodynamics are important. It's just one piece of the puzzle. There's other things and that you're thinking about when you're choosing a valve for a patient. It's not, the only thing that you're thinking about. But for certain patients, it's very important. So it just is one of the pieces of the puzzle that we look at when we're making a choice for a patient.
Awesome, thank you. It looks like We don't have any more questions in the chat. And by the responses of the people who asked questions saying thank you, I think we did a really nice job addressing everyone's questions. With that, I think we can go ahead and conclude the webinar. I want to give a heartfelt thank you to all of our wonderful speakers for giving an insightful and engaging presentation. I love seeing that we still have engagement for the webinar through the end, and we've got a lot of really great questions. So thank you to our audience for tuning in and asking questions throughout the webinar this evening. We hope to see you again on a future webinar or a future program. But until then, have a great rest of your night. Thank you.
Thanks, everyone.
Thanks, everybody.